Hello, everybody. My name is Greg Hanselchuk. I'll be the moderator today. We apologize for the little delay there. We had some IT difficulties. Thankfully, we've got a good crew of communications and IT people here that work through the issue. So, for those of you that have joined us before on one of our webinars, thank you for joining us again and taking time out of your day to be with us. And for those of you that are first-time participants, thank you for having an interest in this presentation today. A little bit of bookkeeping for those of you that have not been here before. We will send you an email within the next 2 weeks that documents that you have earned 1 hour of CE for attending today's webinar. This webinar will also be recorded and placed on the College of Veterinary Medicine CE website. And if somebody watches a video there and then takes a short 5-question test, they will also earn a credit, 1 credit CE. We also record this webinar, and it's planted on the Diagnostic Labs YouTube channel. Unfortunately, you're not going to earn a continuing education credit if you watch it on there. The other things to think about is that we're going to ask you to fill out a survey at the end. And what we need feedback from our participants to let us know what we're doing right and what we can do to improve. And one of the questions will be, what topics do you want us to cover in the future? And we plan on at least having a webinar every other month and probably get to a point where it's every month. We're going to save the questions for the end, but if you have questions during the presentation, you can either throw them in the chat at the top of the screen there, or if you put them in the Q&A, it'll actually be anonymous, so no one else will see your questions. So either way, send us those questions and we'll ask them at the end. If we don't happen to get to your question, we will feel free to contact the presenter. The contact information is there for Dr. Plattner and ask the question then. So without anything else to go over, it's my great pleasure to introduce Dr. Brandon Plattner. Brandon grew up in Northeast Kansas. He has a bachelor's and a DVM from Kansas State University. He then spent the next 3 years as a mixed animal practitioner in Northeast, serving clients in Northeast Kansas and Southeast Nebraska. After 3 years, he then went to Iowa State University, completed a residency in anatomic pathology, and also completed a PhD, and his focus was early pathology or pathogenesis in Johne's disease. After he finished that program, he went to Guelph in Ontario, and he joined their faculty as an anatomic pathologist, and he was there for 9 years. We were fortunate in 2019 to convince him to come back to Kansas, and he's been a faculty member in the diagnostic lab here since that time. He's the leader in both our IHC lab and our histo labs, and presently he is the Ronald J. Marthaler, let me get this right, Ronald J. Marthaler Endowed Professor of Anatomic Pathology. Kind of a big mouthful there. So with nothing else to go on, let's introduce Dr. Brandon Plattner to talk about Clostridium.
All right. Yeah, thanks, Greg, for that introduction. It's a privilege to be here today and just jump right in here to the topic, Clostridial diseases. So here's an outline, what we're going to try to cover today, and I'll say now, hopefully there's some time at the end for some questions. So as Greg said, hold those questions. I'm sure there will be some questions, hopefully generate some discussion here today. I want to start off with some myths, confusions, diagnostic challenges. This seems to be an area that we do see some confusion, and so hope to clarify some of that. And from there, we'll kind of overview the Clostridia. We'll talk about the most important Clostridial diseases of domestic species, and then with all that in mind, I think that will help us sort of consider how best to approach the diagnostic process with respect to these diseases. So a pretty basic approach today, probably nothing too earth-shattering, but I think understanding this pathogen and the pathogenesis really does impact and make our diagnostic approach more successful in the long run. So I'm going to make a few statements here. and then I'll try to defend those as we move through the talk today. So first of all, there's a lot of confusion with terminology, and we'll kind of clarify toxin versus exotoxin versus endotoxin versus enterotoxin, and then enterotoxemia. That matters when we think about these diseases and what we mean by those words, so we'll talk about that. These next two statements, I hope to defend these as we go through, but I'd like to propose that Clostridium perfringens is not usually a significant pathogen. And more specifically, Clostridium perfringens type A is not usually a significant pathogen. And we'll talk about that a bit more. And then really what I want to focus on is understanding the pathogenesis of these diseases will help us work through the diagnostic process, which I've got some points here. What is the disease being produced? What are the lesions? What samples are you submitting, and what tests are you requesting? Clostridia are not all the same. They cause different diseases or no disease, and so they require some thinking and potentially different samples and tests to establish a definitive diagnosis, and we will try to clarify that as we go. Okay, so let's start with the definitions here. Again, some of this should be pretty basic, but it does seem to be a point of confusion frequently with these diseases. So endotoxin, this is the LPS of the outer membrane of gram-negative bacteria. These are mostly gram-positive, so we're not even talking about endotoxin today. But toxin in general, a poisonous substance, metabolic product of an organism. That's similar to an exotoxin, which just means that toxin is being produced by a microbe and then released into the environment. So enterotoxin does come up a lot with Clostridium perfringens. The definition of this word, though, is simply that toxin is produced by a microbe, in this case Clostridium perfringens, and released into the intestinal tract. And so enterotoxin is a generic term that means any toxin produced by a bacteria in the intestine. But there's some confusion here. The toxin known as CPE, which we'll talk about in a few minutes, is a specific enterotoxin, a typing toxin of C. perfringens. So sometimes that's a bit confusing. We'll talk about that in a bit. Enterotoxemia, a lot of times the clostridial diseases all get called enterotoxemias. That's probably not accurate. An enterotoxemia is a disease or a syndrome that's produced after absorption of the enterotoxin from the intestine into systemic circulation. So to say there's enterotoxemia, you're implying that the toxin is absorbed in the GI tract but has an effect systemically in some other organ. Some Clostridium perfringens cause enterotoxemias, others do not, and we'll cover that. Okay, so let's talk a bit about Clostridia. These are present commonly in animals, all animal species, and humans, in dirt. So they're present normally in many places. A minority of the species Clostridium are pathogenic. However, it's well established that Clostridium perfringens, C. difficile, and some others certainly are the causative agents of significant enteric diseases in humans and animals. We know that is true. Pathogenic Clostridia can broadly be subcategorized into three areas. So neurotoxic, this would be diseases like tetanus and botulism. The histotoxic Clostridia would be diseases that mostly cause lesions in muscle or liver. So blackleg, gas gangrene, hepatitis would be examples of that. And then what we're going to talk about and focus on today is the enteric Clostridia. These are those that cause usually either enteritis, enterocolitis, and or enterotoxemias. Gram-positive anaerobic rods, these bacteria produce heat-resistant spores, which has a significant role in the pathogenesis of the agent. And by definition, pathogenic Clostridia cause disease by production of toxins, and those toxins mediate significant cell and tissue damage. That's an important concept to understand as we think about how they cause disease. So this is some data from a colleague, friend, another pathologist, colleague of mine, who I've had the privilege to work with over the years. Some of the material here does come from Paco Uzal at UC Davis. He is probably the lead expert in the country, probably the world, on Clostridium diseases. But this is some data he looked at. And basically the idea is this is in sheep of various ages of sheep, adults and young lambs. But the point is that in 80% of animals, healthy animals in this study, Clostridium perfringens could be cultured from the intestine. So it's safe to say this has been shown in other species as well. It's commonly present in healthy animals. And if we look at those and subtype those, the vast majority of them are type A's. There's a few of the other types there that you can see, but that's, again, in normal animals, and that's an important thing to understand as well. Lots of words on this one, but let's just, I think it's important things to think about. So the virulence of Clostridium perfringens is attributable to its production of toxins. There are probably 20 or so toxins that are described. Most of these toxins are produced during germination and vegetative growth of the organism. With the exception of CPE, I mentioned that one earlier, that specific toxin is known to be produced during the spore phase as well, so it's a little bit unique. Most of these toxins are plasmid encoded, and so the significance of that is probably for us is that they can move. They've been shown to be picked up by other Clostridium perfringens or even other bacteria, so I think that's something we need to consider as we think about, again, the diagnostic process here. Of the toxins produced, 6 major toxins are what we call typing toxins. So these are the ones that we use to define which toxinotype of C. perfringens we have. Those are alpha, beta, epsilon, iota, CPE, enterotoxin, and then net B. Those are the typing toxins, the major toxins, again, which define the type. The 7 toxinotypes of C. perfringens are A, B, C, D, E, F, and G. We'll talk about this in a bit more detail as we go. In addition to the major or the typing toxins, there's a number of non-typing or what are often referred to as minor toxins that can also be produced by a number of these strains. I've listed a few of them here. It's not inclusive, but kappa, lambda, beta 2, net F, etc. These are, again, non-typing or minor toxins. These are mostly thought to or have been shown to contribute to disease. Some of them are known to be critical for disease. But of themselves, none of them are sufficient to produce disease in any of the species. Probably there's a lot of synergism here. So beta-2 toxin with alpha toxin may be more likely to produce disease. We'll come back to that. Clostridial toxins form pores. They cause cell membrane injury, or they affect various cytoplasmic processes. Some of these toxins are active at secretion, but destroyed by trypsin. The best example there would be the beta toxin of Clostridium perfringens type C. Others, however, are secreted as prototoxins, which are activated by trypsin, and so they require that for activation. An example there would be epsilon. So there's some nuances to the toxins as well that is critical to understanding the diseases here. A brief comment on C. difficile. We'll talk about this a little bit later, but it's very similar. It produces 3 different major toxins. Also a source of confusion, but they are known as toxin A and toxin B. So the toxin A, so it's toxin of C. difficile A or toxin of C. difficile B. These are not the same as the alpha and the beta toxin of C. perfringens. So that's an important thing to note the difference. There's also a C. diff transferase that probably, again, is synergistic with the first 2. So to summarize this is a table that really shows sort of all that information in a table form. So toxin genes along the top here, the toxin typing major genes that I mentioned before, alpha, beta, epsilon, iota, CPE, and net B. Along the left-hand side here in the vertical column is the C. perfringens toxinotype. So a couple things to note on here. All strains produce the alpha toxin. So the alpha toxin is present in all of the strains. And the CPE toxin can be produced by all of the strains. So really, it's the presence or absence of the other toxins that define the toxinotype. So for example, if we have only alpha toxin present, that will be a C. perfringens type A. If we have alpha toxin plus beta toxin, that will be a C. perfringens type C. And on down the line, type D is epsilon toxin, and type E is iota toxin. Okay, so this is sort of the basic toxinotyping strategy. Again, highly important for understanding these diseases. We'll come back to this as we go. So the pathogenesis of Clostridial-induced diseases, lots of controversy and debate here, but I think this is pretty well established. These are organisms that are normal inhabitants. There's some something happens that causes an enteric microenvironment change that's favorable to the massive expansion of luminal Clostridia. Probably other bacteria are involved here as well. Proliferation of this bacteria occur, and they elaborate and produce the toxins, which then result in the damage to the intestine, and we see that as necrosis and hemorrhage. So when I say microenvironment change, what the heck does that mean? It can mean a lot of different things, and I think there's a lot of misunderstanding and confusion around here. Maybe there's some inadequacies in how well this is understood. Perhaps I will admit that, but probably this is a change in feed, abnormal nutrient, carbohydrate-rich ingesta. Antimicrobial therapy can probably affect this, altered pancreatic exocrine function, reduced motility. Other primary infections have been linked to this as well. And a big one, particularly for Clostridium perfringens type C, is trypsin inhibitors. And we'll talk about that a bit later as well. So in summary, very important thing to understand here is the pathogenesis of intestinal Clostridial infection requires the presence of the organism, change in the microenvironment to allow proliferation of that organism, toxin production, and then tissue damage. So that's how the basic steps that I think are important to keep in mind. Okay, so these diseases, almost all of them manifest as necrosis and hemorrhage in the intestinal tract. So here's a young foal, 3-4 days old foal. Acute death, seemed to be doing fine, sudden unexpected death, and this intestine is necrosis and hemorrhage, so necrotizing and hemorrhagic enteritis. This was a case of Clostridium perfringens type C. Another example, again, necrosis and hemorrhage. This is a piglet. Lots of necrosis, lots of hemorrhage. This one also we can appreciate here in the wall of the intestine, emphysema. So emphysema is a frequent attribute of these diseases as well. You see that with a variety of toxinotypes. This is a recent case that was submitted through the VDL, a young beef calf that again seemed to be doing fine one day, next day was a little bit off, and that evening was found dead. And on necropsy, the findings were intestinal hemorrhage and necrosis. As you can see here, this is the opened intestine, the mucosal surface. You can appreciate instead of a smooth, glistening surface, this is irregular and thickened and friable tan material. So this is fibrin here and necrotic debris on the surface. This is fibrinous to fibrinonecrotizing and hemorrhagic enteritis. Histologically, this is that intestine. You can appreciate here from the histo-subgross view, lots of intestinal mucosal damage. There's loss of the intestinal epithelium. There's a lot of necrotic debris here along the surface. There's expansion of the wall of the intestine with hemorrhage and necrotic debris. And then you can appreciate all these clear spaces. This is emphysema. So classic lesions associated with Clostridium perfringens. This is a closer view of that same intestine, again, just showing the necrosis and the hemorrhage and destruction there at the epithelial or mucosal surface. Histologically, we can apply something like a Gram stain to these intestines and typically find large numbers of robust, thick, gram-positive, elongated rods. In the intestine, we expect to find lots of mixed bacteria. And so this is not a confirmation, but I like to add these Gram stains on these cases, and lots of big gram-positive rods is supportive of the diagnosis, although we would still want to do additional tests. Okay, so the diagnostic testing approach then, I think this is what I want to sort of hit on here pretty hard today, is the definitive diagnosis and confirmation of Clostridial disease requires several things. You need disease, you need some manifestation of clinical signs or lesions. If it's not causing lesions or clinical signs, there's no disease, okay? So in addition to that, we also need the pathogenic bacteria. And typically we'll start with an anaerobic culture of intestinal tissue and or contents. It's the best test to select first. Intestinal contents, intestinal tissue, anaerobic culture. We can identify Clostridium perfringens, but since we know that they're frequently present, we need to do more. So we need to identify toxins. There's a couple of ways where we can do this in the lab. The first one, the most common way, is genotyping. We do this by PCR, where we take the isolate identified at culture, send that to molecular diagnostic lab, and we perform genotyping or toxinotyping. We require the isolate there. So this test is only done once you identify the isolate by culture. And this assay is detecting by PCR the toxin genes that are required for the production of the toxin. from a pure isolate. So we're looking for the toxin genes here based on the pattern of expression of the genes, and that's Clostridium perfringens. And the table that we looked at a little bit ago will be toxinotyped as one of the 7 toxinotypes there. Some panels that we offer here do detect the toxin genes directly, say for example in feces. So the places we see this are the C. diff toxins A and B, and actually C. perfringens alpha appears in a few of the panels. So I guess my comment on that would be is I think that can be a valuable thing to know, but just remember, if you're direct testing feces with PCR, there could be some disadvantages. We're not linking it to a particular bacteria. We're not linking it necessarily even to a particular lesion, which can be open the door there to some misinterpretation. PCR in intestines directly can reduce can reduce the concentration or dilution, so there can be some other issues. We know that these are plasmids that can maybe jump around, so I think there's some things we have to consider when we're interpreting a direct fecal PCR, and what's the significance of those results is important to keep in mind. Okay, so that's genotyping, one way we can identify the toxins. One way we can identify and toxinotype the C. perfringens. The second way is actually a toxin ELISA. Now, we don't do this test here. Not too many labs actually offer this. I think maybe 1 or 2 labs in the US offer this test, but this is a great test. Actually, here we're detecting the toxin, the protein toxin from intestinal contents. The reason we don't offer this test is manifold, actually. It's expensive. It comes as a 96 well plate. I think it's produced by maybe one company in Belgium, in Europe, and so they're expensive. If the tests are run one sample at a time, which they need to be, the cost is pretty high. You have to run a whole strip of controls. I've worked on this test a bit when I was at Guelph. If you can run the whole 96 well plate, the cost comes down, but I think there's, again, some of those complicating factors are why we don't actually offer this test. But the test is a reasonable test to assay the presence of those toxins. Remember also that some toxins, in particular the beta toxin of C. perfringens type C, is highly sensitive to trypsin. So if you assay a sample of feces for beta toxin that's been, sitting around for more than a few hours, it's likely that we won't detect it because the toxin is probably gone. One of the questions that comes up here often is, could there be toxin genes present by genotyping, but actually no toxin production? And I think that's a great question. I don't really probably can't answer that exactly, but my impression is that usually that's not the case. The toxin genes are probably mostly present and expressed in proliferating bacteria. So possible. We did some work with Clostridium perfringens type D, and it was rare to find the toxin gene without the toxin production. So I think that's a great concern, worth considering, but I think it's fairly rare actually. Okay, so that's the diagnostic process, and I wanted to just stop here. I guess I'll say, if you got any questions, maybe hold on to them till the end, but that's kind of where I wanted the major part of this to be, is that this is how we ought to be thinking about these diseases. The rest of the time, just going to work through some of these diseases and kind of talk through some of them, some specifics on these. So again, working from this table, our toxinotyping scheme, let's go through some of the most common Clostridium perfringens infections to happen in domestic species. Okay, so we'll start with Clostridium perfringens type A, probably one of the more controversial ones. This is by definition C. perfringens plus alpha toxin only. Again, some strains produce other minor toxins such as CPE or beta 2 or NET-F, but it's the alpha toxin that defines this toxinotype. This is the most common C. perfringens type that we'll find in the environment and in the intestine of clinically normal animals, so beware of that. And also remember that all C. perfringens toxinotypes produce alpha toxin. Okay? The disease caused by this pathogen that we know of for sure is gas gangrene in humans and animals, particularly if there's production of this enzyme, perfringilysin O. This is the cause of yellow lamb disease in sheep. This is very rare. I've never seen a case. Causes intravascular hemolysis. It's also the agent that's been associated and linked pretty well, I think, with abomyositis and tympani in calves, so abomasal tympani and necrotizing and hemorrhagic abomyositis in calves. Other than that disease, though, I would say for the most part, there's a number of other proposed syndromes linked to Clostridium perfringens type A, including in foals and adult horses, neonatal pigs, lambs, calves, dogs, various enteritis, gastroenteritis, enterocolitis. But I would say, based on what I understand about this, largely this is still unproven and not definitively known to be the case. Having said that, Clostridium perfringens type A strains that also produce beta-2 toxin may be more likely to be involved in disease. So again, another reason why toxinotyping on these I think is really important. And we'll come back to that in a bit too. So the exception to that then is dogs and foals. So necrotizing enteritis of foals and necrotizing or hemorrhagic canine gastroenteritis, formerly known as hemorrhagic gastroenteritis, HGE. If those C. perfringens type A strains also produce NET-F toxin, that has been linked definitively to these syndromes. So we do test for NET-F toxin in molecular, and so again, strains, type A strains that also produce NET-F in dogs or foals producing the appropriate syndrome are likely significant in the cause there. This is the disease that they cause, necrosis and hemorrhage, and possibly emphysema. This is a foal on the left, necrotizing enteritis of foals, and over here this is a dog from a case of canine gastrointestinal hemorrhage syndrome or hemorrhagic diarrhea syndrome. So again, for C. perfringens type A, we know that it can be cultured from feces of healthy animals, probably from you too. Large amounts of alpha toxin can be present in feces of healthy cattle. Always keep that in mind. So be cautious with how we interpret the findings from this particular toxinotype. So I would propose that the isolation of C. perfringens from the intestinal content of normal or diseased animals has no diagnostic relevance alone. Isolation of C. perfringens type A, confirmed by genotyping, from the contents of normal or diseased animals has no to minimal diagnostic relevance alone. And again, detection of alpha toxin in the intestinal contents has no diagnostic relevance alone. On its own, it's insufficient to establish a diagnosis. However, in an animal with appropriate clinical signs or appropriate lesions, the isolation of C. perfringens type A, especially if in high numbers, and if the isolate produces beta-2 or NET-F toxins, may be clinically relevant. So you've got to interpret this in the context of the disease that they're producing before we assign it significance in the pathogenesis. Okay, Clostridium perfringens type B, this will be a quick one. Not diagnosed in the Americas. I think that's probably enough to say. This one produces beta and epsilon toxin, causes lamb dysentery in some parts of the world, but we're going to skip over that because we don't see that one here. Clostridium perfringens type C probably gets a lot of press too. I won't say it's common, but I would say it's one of the more famous toxinotypes of C. perfringens. Mostly causes diseases in the very young. This produces beta toxin, which is a very potent pore-forming toxin. Some of these strains also produce enterotoxin, but this beta toxin is very necrotizing and very sensitive to trypsin. So beta toxin in the presence of trypsin, which is high in most adult animals' ingesta and feces, is broken down very rapidly. So we don't see this disease in adults very frequently at all. Beta toxin in the presence, though, of trypsin inhibition is highly potent. And so that's a significant player in the pathogenesis here. This is the cause of sporadic disease, mostly in the very young. 1 to 5 day old lambs, kids, piglets, calves, foals, and in humans. If you're familiar with this whole story in the 60s, this was causing significant morbidity and mortality in a tribe in Papua New Guinea. It was discovered that their diet consisted of C. perfringens contaminated pork, along with sweet potatoes, which are a known trypsin inhibitor, which was the combination there that created such significant disease. So sudden onset of syndrome, sudden death often is all we see. Severe necrosis and hemorrhage of the intestine. Some of these cases will also be accompanied by neuroscience, so there's probably an enterotoxemia element here too, with some of these toxins that become bloodborne and affect different organs. Important here to consider the trypsin inhibitors, and the one that's relevant for us is colostrum. So significant trypsin inhibitor. So in neonates, this is a large factor in why we see this disease in neonates because of the colostrum's inhibition of trypsin. Others include sweet potatoes, soybeans, pancreatic disease, etc. Okay, so to diagnose C. perfringens type C, We need the appropriate clinical signs. Sound like a broken record here, but we need clinical signs. We need to isolate C. perfringens by anaerobic culture, and then we need genotyping to demonstrate the beta toxin. Okay, and remember, this is a toxin that's rapidly degraded by trypsin, so the ELISA in this case may be less useful. C. perfringens type D, this one also is probably kind of famous. This is C. perfringens with the epsilon toxin specifically. Some strains also may produce minor toxins. Epsilon toxin is also a pore-forming toxin. It increases vascular permeability. So this is secreted as a prototoxin and requires trypsin activation, so the opposite of beta toxin. This is an interesting toxin, lethal for mice. The CDC has noticed this, and it's on one of the important lists of CDC of significant toxins. This has also been linked to human MS, of all things, so just to be aware of that. The disease caused by type D C. perfringens is also sporadic, usually sheep and goats, and less commonly cattle. This is usually in animals over 2 weeks of age. We know this commonly as overeating disease or pulpy kidney disease. This is the classic enterotoxemia, where we have C. perfringens in the intestine, production of epsilon toxin there, which is then absorbed into the bloodstream, but has its effects distantly. And in sheep specifically, this is not a GI disease. We don't see any evidence of diarrhea or enteritis in the vast majority of cases, but this is known as leaky disease because the toxin goes systemic, produces vascular permeability and fluid exudation all over the body, in the brain, in the heart, etc. Sheep are not the same as goats, and so in goats, this disease can be a couple of different presentations. Acutely, it can look a lot like the sheep disease. More chronically, though, it does produce enterocolitis. So in goats, we may see enterocolitis, and sometimes we see both. Cattle, I think this disease is pretty rare. It's been described very infrequently. It's been experimentally produced, so I think it can certainly happen, but it's quite uncommon. This is a sheep with Clostridial perfringens type D, again, sudden death, and the necropsy lesions show lots of fluid. This is hydropericardium in that animal. In the brain, they can have things like cerebral edema, cerebral or coning of the cerebellum. We can often see the classic lesion that we'll see are these two areas of necrosis, focal symmetrical encephalomalacia. This is a toxin-mediated injury in these areas of the brain, the thalamus, midbrain, corpus striatum, etc. But finding this lesion in the brain of a sheep that's suddenly dead is diagnostic for C. perfringens type D. Histologically, the lesion looks like, just as we would expect, mural vascular edema. This is very characteristic again. This is present in 95% or more of sheep that are affected with this disease, and the finding of this lesion in the brain is diagnostic and confirmatory for this disease. In goats, we can see enterocolitis. This is spiral colon here, and you can see hemorrhagic and fibrinonecrotizing colitis. But we would not see this in sheep. So summary of C. perfringens type D, we need the appropriate clinical signs. Again, often this is sudden, unexpected death. In sheep, we will see edema and fluid in multiple organs. Pulpy kidney disease, pulpy kidneys. I think every sheep that I've ever done a necropsy on has pulpy kidneys. They autolyse very quickly. So that's a tricky one to document, but this toxin can have an effect on renal tubular epithelium. But we will see it predominantly as fluid in multiple body cavities. Cerebral vascular mural edema is the lesion that we're looking for, so we need histo on these cases to make a definitive diagnosis. In goats, again, acute diseases like sheep, but in chronic diseases, they cause enterocolitis. An important comment to make about goats is, in goats, though the disease can look grossly like sheep, most goats, do not have vascular or perivascular or mural vascular edema. A low percentage of those animals do, so the histo in goats can be less rewarding than it is typically in sheep. In cattle, again, it's a fairly rare disease. Histology is important in this one. If we find the histologic lesions, we can confirm the diagnosis. But we can still culture these intestine. So it seems odd, and you have to be aware that this is an enterotoxemia. Though you're not seeing lesions in intestine, the intestine is still the choice tissue for culture, anaerobic culture, because that's where we'll find the C. perfringens. And if we do, then we genotype it and find epsilon toxin. Clostridial perfringens type D is then confirmed. Clostridium perfringens type E also is kind of a more recent one. I think there's not a lot known about this disease, but this is C. perfringens with iodotoxin. Some of these also produce CPE or beta 2. Again, relatively recently described in calves and cows and lambs and rabbits. I think it's still pretty poorly understood. I've seen a handful of these in the lab. So again, if we see hemorrhagic enteritis with Clostridium perfringens and iodotoxin, we'll attribute that to Clostridium perfringens type E. Some of these animals can also have evidence of enterotoxemia. So again, same as before, clinical signs, culture Clostridium perfringens and genotype it is the way to make the definitive diagnosis. Clostridium perfringens type F, this is a new one. So F and G are both fairly new additions to the genotyping or toxinotyping strategy. This is a highly prevalent food poisoning and very commonly antibiotic-associated diarrhea in people. So this is a human disease. Maybe this we see in dogs and horses, but again, not fully understood, not well characterized. These are essentially CPE secreting C. perfringens type A strains. And so we've known this to be an entity in people for a long time, but these were recently reclassified. So if it's a C. perfringens type A strain, so alpha toxin also producing CPE toxin, those now classified as C. perfringens type Fs. I'm not sure it has a big impact on animal diagnostics actually. But the summary here, again, diagnosis is the same as we've been talking before. We document it by genotyping. C. perfringens type G, I'm also going to go past this one pretty quickly. This is chicken necrotic enteritis, so only seen in chickens. The toxin here of significance is net B-like toxin. This disease is often associated with coccidia, but again, chickens, we would do the same process for diagnosis here as we would with the other Clostridium perfringens types. Okay, before we wrap this up here, just make a comment on Clostridium difficile or Clostridioides difficile. Name has been changed, so you'll see that. Just keep up the confusion, I guess. But this is C. diff. I just call it C. difficile. That way we're good either way. But the toxins here are A and B. Again, those are different from the alpha and the beta of C. perfringens. This is probably the main cause of antibiotic-associated diarrhea in humans and in adult horses. However, in pigs and foals, it's probably not antibiotic-associated. This is often associated also with hospitalization. We can find C. diff normal in some normal dogs and cats, as well as in some other species. So I think we always have to be careful there. But this produces a fairly similar lesion that we see with C. perfringens, necrotizing hemorrhagic enteritis. Again, this is a toxin-mediated disease. In small intestinal, in young foals and larger horses, adult horses, it's often more distal intestine and large colon. Important disease in piglets, major cause of mesocolonic edema and colitis in pigs. So again, the diagnostic process, though, is exactly the same. We need the lesions. Isolation or culture of C. diff is very difficult. Its name is given there for a reason. So only with specific enrichment is that successful. So typically we will diagnose this by going right to detection of the toxins in the intestinal contents of A and B. So we have the correct lesions here. I recommend going right to demonstration of the toxins, usually by PCR. This is one of the reasons why we offer TCD-A and TCD-B toxin gene detection directly from the feces, because this is a difficult one to culture. We don't often culture this successfully. Okay, so hopefully that makes sense. Okay, finally here, there's a bunch of other clostridial diseases that we're not focusing on today. Clostridium piliforme Tisser disease also causes colitis, but it also typically is associated with hepatitis and myocarditis as well. So again, a full necropsy is important here. Paraclostridium sordellii has been linked with enterocolitis in horses. There's not a lot known about this. In dairy cattle, jejunal hemorrhage syndrome often gets linked with or grouped with Clostridial perfringens diseases. It's been C. perfringens type A has been linked to this, although I think the data are really not very convincing. Maybe we're not sure yet. This has a unique lesion that it produces. I think the jury is still out for that. Several studies recently have indicated there's no association with C. perfringens or type A or alpha or beta 2 toxin actually. So I think this is unproven at present. Quail disease, rabbits, blackleg, etc. So I have to put a few images in a presentation here. So horse with necrotizing and hemorrhagic enteritis that also has hepatitis. This is Tisser disease or Clostridium piliforme. So again, that clinical information is really important. A bird, quail with necrotizing and hemorrhagic enterocolitis. This is Clostridium colinum. And then this is just a reminder of jejunal hemorrhage syndrome in dairy cattle. Probably not a clostridial disease. And then sort of lastly, as we wrap this up here, Clostridium shovii, blackleg disease. So that's a different sample set, a different test that we're going to use to diagnose that. This is just an example of necrotizing and emphysematous myositis from a bovine. So one last shot at this here. Diagnostic testing. We need to see the disease. We need to identify the bacteria with anaerobic culture, and then we need to genotype those bugs to document and prove that that is the cause of the disease. So a plug here for the submission form. Highlighted a few things here. History is always important. Signalement is always important. We know that some of these diseases are more prevalent in various signalements and ages, so that makes a significant or plays a significant role in the diagnostic process. Fill out the histories. Anaerobic culture is a great place to start on these. Submit intestine for anaerobic culture. Once we have that, we can then proceed to PCR. We have this on the form here in cattle as this test, which is Clostridium perfringens culture plus PCR. So if you check this one, we're going to culture. If we get C. perfringens, it goes to molecular for genotyping. This down here under histopath that says FA Clostridium causes a little bit of confusion sometimes with submissions. This is referring to, it's under histopath. This is referring to shovii. So this is for a case that you're suspicious for blackleg. Submit muscle, not intestine for this. And we're going to do the blackleg FA on this one to make that diagnosis. But I think, again, important point is that we need signalment history. We need to know what lesions you're seeing. That really is helpful as we work through these diseases, and it increases the confidence of our diagnosis very, very significantly. Reference list here, there's a lot of references, a lot of work has went into this, and so I pull heavily from Dr. Uzal. Most of these papers here have his name somewhere in the title list, so I appreciate his contributions to this as well. And with that, I will stop, and I think we have time for some questions.
Thank you, Brandon, very much for that presentation. A lot of good information. Again, we apologize for the blurriness of the slides. The recordings that we'll plant on either our YouTube channel or on the CVM website will not be blurry. So if you want to go back and kind of review that part of the presentation, it should be normal. So this is from me, actually, a question for me, Dr. Plattner. You mentioned in the very first slide that Clostridium A is not a significant pathogen. So, and you and I have talked about this, that we do see issues in milk replacer fed calves on dairies that have poor feeding management. So back up your idea that it's not a significant pathogen. What do you mean by that?
Yeah, I think what I mean by that is isolation of C. perfringens type A alone, I'm going to be very reluctant to call that a pathogen unless there's some other evidence of disease. So pair that with disease, pair it with hemorrhagic diarrhea, pair it with a lesion, then I'm going to modify that statement a bit. But I think, again, we will often get cases where I have no evidence of disease. If we culture C. perfringens and even genotype it as an A, I don't have any idea how to interpret that without some more information. And we get it frequently from normal animals. So I'm just, I guess the point of saying that may be a bit too provocative, but I want to really emphasize that you have to question the significance until you know more information.
So can we have a case where the toxin production is so great that we can have an acute death where there aren't any lesions other than sudden death? Sudden death's a clinical sign. Can it be a Clostridium?
Yeah, that's a good question. I mean, fundamentally, as a pathologist, I think that would be fairly uncommon because, I mean, the way these pathogens cause disease is by the production of the toxins and toxin-induced injury. There probably are some of the enterotoxemias that could cause that, would be more likely to cause a death due to cerebral edema or something like that. So depends on which toxins it's producing, possible. But again, without linking it specifically to either, and maybe it's just clinical signs, but I think there ought to be something that we could link to the agent before I would assume that it's significant biologically.
Is it helpful to check a direct fecal for Clostridia in dogs or cats with bloody diarrhea? And how would you interpret that?
Yeah, I mean, I think that's a great question. We get those a lot. I get those phone calls sometimes from VHC clinicians who have folks who call and say, what does this mean? And I think my response will be similar to theirs. I think it's really difficult, probably impossible to interpret without more information. You know, the beauty of the panels is that you can look for other things at the same time. So if we can rule out some of the other causes of bloody hemorrhagic diarrhea in dogs and cats, you've gone a long ways there. So, you know, if you have nothing but Clostridium perfringens, maybe it is playing a role. But again, I think I would read that with some reluctance to assign it as the cause without more evidence. So specifically in an animal that's again, maybe you're not running PCRs if they're normal, but I'm always hesitant to assign it significance until I know that it's causing some disease. So I think, again, in a panel, probably it is helpful, mainly though because we're ruling out a whole bunch of other things that I think are probably more likely to be causing disease in those animals.
So on the bovine side, we do not have to my knowledge, we do not have a commercial Clostridium perfringens type A vaccine. Is there any evidence out there that the C and D toxoids provide some type of cross protection against A?
Yeah, that's a good question. So again, depends on how the vaccines are made, but the C and Ds are toxoids, right? So those I think would have the evidence that I've seen on those. There's no cross protection for type A, which I think makes sense. Those are specific toxins and toxoids that those are producing. I think the jury is still out as far as how protective would a C. perfringens vaccine be against type A's. I think there could be some broad protection and cross protection there from a bacterin perhaps, but from a toxoid, I think the answer would be unlikely to have any cross protection. I think there's some data in the literature to support that actually.
So is there any value to actually doing CFU counts on Clostridium? We talked about this before.
This is a great question. So specifically with Clostridium perfringens type A in cattle and in other ruminants, actually, there was some early work that showed if you get greater than 10 to the 6 CFU per gram of feces, for example, that could be evidence to support a role in disease. However, I think the thing that we're overlooking there perhaps, and maybe has been sort of debunked in more recent work, is that depending on the timing of the sample, if you take the sample and let it set for 12 hours or 24 hours, we know those Clostridial perfringens are proliferating. So I think that's the challenge, is knowing how much of that proliferation is post-mortem after death or how much of it actually reflects in the animal prior to death. So if we could standardize for that, I think there's potentially a role for quantification, but there's so many variables. It's just, again, really hard to interpret, I think.
Would you consider limiting your report of Clostridium perfringens type A to samples that demonstrate Clostridial overgrowth on gram stain?
Okay, I'm not sure I'm following that question. Would I consider
limiting your reporting of Clostridium type A to samples that demonstrate an overgrowth of Clostridial on the gram stain?
Yeah, again, the overgrowth is hard to quantify because it's the intestine. We expect to see lots of bacteria there. But yeah, I think histo is helpful here. So lots of C. perfringens consistent bacteria in the intestine I think can be helpful. IHC, immunohistochemistry, is also an option. There's immunohistochemistry available. We don't actually have it in our lab, but we probably could work on that. It's one that I've had on my list for a while where, confirming lots of C. perfringens in the intestine I think can be helpful. But again, I'm probably going to be looking to see if there's a lesion there in that animal. So histo helps me with that as well.
I'm curious how frequently you obtain negative FA results and yet recover the organism on culture.
Well, that's a question I'm not sure. So again, FA, we're doing not for Clostridium perfringens, we're doing FAs for Shoviae, Septicum, etc. That's a great question. So the FA can be done on fresh or fixed tissue. We do those on both. I don't know, Greg, maybe you could answer that question. I'm not sure how many of those we've actually tried to culture at the same time from the same animal.
I've never looked at it, but I think we'll go back in the data and look at the sessions because it's something that is a good question. Yeah.
My sense is that it would be fairly few. I think that FA is really good, actually. I like that test. And so I think we don't miss too many of those, actually.
Is Clostridium the only organism that can cause gas gangrene in humans?
In humans. I don't think so, but that is not, I wouldn't say that's an expertise of mine. So no, I don't think so. I think we can see that with other organisms too. But I'm not 100% sure on that one.
I'm looking for some more questions here. So not cost effective to even look for Clostridia on the fecal slide. Should small animal vets check direct stained fecals?
And I think we would be looking there for an overgrowth of Clostridium. So I don't know, I'm going out on a limb here a little bit. I almost wonder if that would be more helpful, just from the sense that you're getting a very fresh sample that you're evaluating. At least we would know that the organisms that we're seeing would be, probably fairly representative of what we're getting in the animal, which is one of my concerns with evaluating growth numbers and colony counts from culture samples. So I think that could be some value, but again, I'm always going to be needing to link it to a disease or a clinical syndrome, et cetera. So yeah.
And then one last comment that just came in. It's about type F. It says the common foodborne illness associated with temperature abuse in ground beef. So is type F common in beef feces and GI tract? Another good question.
Yeah, that's a great one too. I don't know. F and G are recent additions to that typing scheme, and we've recently in the molecular section, Dr. Knoll and Dr. Bai have modified their panel actually to include the toxins there. So I don't know how long we've been testing for that. I don't know. I'd have to ask them how many they've detected, but I don't have any evidence to say yes on that one for sure. I don't know the answer. It's a good question though.
And a question that I hear a lot out there, and I've always wondered it myself, is, and it may be a little bit out of your wheelhouse, but I don't think so. But is it beneficial to use Clostridium vaccines in very young calves, 2 days old? Do you think, what do you think about that?
Yeah, I can lay my cards on the table. I'm fairly reluctant to put a lot of faith in the Clostridium vaccines in most situations. You might be able to argue for an exception there. Just because, it depends probably, the answer to that question probably depends mostly on what is the vaccine, how is it made. I think a vaccine aimed at the Clostridium perfringens pathogen or the bacteria is probably unlikely to be able to have much effect on a disease because they're toxin-mediated diseases. So I think as a general rule, probably no would be my answer, but there might be some situations where there could be some benefit. And I think, again, from the literature perspective, what I've seen has not shown a lot of evidence for and in support of that as a protective mechanism, would be my understanding.
Just another question. So if I have an adult dog with bloody diarrhea, how do I diagnose Clostridium before it's dead?
Yeah, I think there's a great place for, other things can cause bloody diarrhea in adult dogs, right? So I think that's the value of the panel to me, is evaluating the panel will be helpful to rule out a lot of those common diseases that we have. Bacterial enteritis in dogs is actually quite uncommon. We don't see that very often. So I would probably suggest to run the panel. That's also going to take a little bit of time though. So in a clinically ill dog, you may need to empirically treat that dog. I'm probably not the best person to give advice there, but I like the idea of the panel in that case because it gives you a broad perspective. But I would be fairly cautious again to blame the disease on the diagnosis of alpha toxin. Maybe what we need to be testing for in that sort of situation actually is net F toxin, which is linked to that disease in dogs. That might be a better one. Maybe we can talk to molecular. That'd be a discussion to have with them. But that toxin I think would be more beneficial than alpha toxin because again, every Clostridium perfringens produces alpha toxin. So I think you have to be careful how you interpret it.
So one of the common things that we do for Clostridium type A is to administer antemortem. We administer C&D antitoxin. Is there evidence to suggest we have toxin protection against C&D when we're talking about perfringens type A?
Yeah, again, that's a great question. I don't know. I think no, but I could be wrong. You have any response to that, Greg? Do you know?
No, I just know I always did it, and sometimes they lived, sometimes they didn't.
Yeah, and I've had, I'm getting into, shouldn't wade out here, but I've heard various different practitioners say that, when they're suspicious of Clostridium perfringens overgrowth, they'll do various things, including that, but also probiotics, et cetera. And that may not be a bad idea. I don't think there's a lot of science out there to prove that right now, but it seems like a reasonable approach. We assume, and I think we have evidence to show that these are diseases of alteration of the microbiome. So if we can address that, I think in a lot of ways, a lot of these diseases are fundamentally nutritional. And so if we can address that and help the stability of the microbiome, I think there's some potential there for some benefit.
We have time for one last question. I had it here, and I lost it. What role do you think Clostridium play in toxic scours prevalent in Dakota calves, usually over 10 days of age, very lethargic, but not that dehydrated?
Yeah, that's a great question, which means I don't know the answer.
You're not in the Dakotas, so it's
yeah. So again, I would, any case we get like that, I would start with sort of a full workup, and let's rule out some things, if nothing else, would be the place to start. It's certainly possible that it's playing a role, but I think we don't know the answer until we look. You don't know until you look, right? And so I think, again, ruling out some common things, some other things would be the place to start there. So I'm not saying, don't take away that it's never important. But I do think we overinterpret the importance of it based on, detection of C. perfringens or alpha toxin too often. So I think we just need to interpret them wisely and based on what we know to be true about these diseases and the pathogens.
Very good. So we're going to call it a day. If we didn't get to your questions, feel free to email Dr. Plattner if you have questions, or call KVDL Client Care, 866-512-5650. And they'll transmit you to somebody that actually can answer your question. So again, thank you all for joining us. Be looking at your email. We'll plan on having another webinar in August on a totally different topic. Have a good day.